Yeah.
Just be careful with your
GPs that we know will, I'm sure he's going to give you wise advice as to what to get out of GP. Thank you.
Wow. Thank you very much. Now that was a very high bar to jump over, and I hope to be able to meet it. Now it's a very interesting topic, isn't it? You say getting the best from your GP, because if I keep talking, you're just going to find out what the GP wants to do for you, but it might not necessarily be what you want from the GP. So what I'm going to do is actually work the group. This talk is going to be effective only if you help me work it. You've got to answer questions. What does getting the best of your GP mean to you? So if nobody volunteers, I'm just going to point at random individuals and take oxygens. So, what does it mean to you, getting the best from your GP? What do you want from your GP?
Information.
Information. What else?
Referral.
treatment and satisfaction.
Treatment and satisfaction. Referral.
Support.
Discussion with different things you could do for it.
You want to know options and you want support.
Yes.
Not to be rushed out the door after
Thank you. Be listened to and understood in given time.
To be encouraged by him when you think you're doing the right thing.
A pat on the back, not a back.
Prescription.
You need to renew prescriptions. Good.
We need the correct prescription.
Oh. Oh. All right. Look, can I tell you that amongst this group, you have already mentioned all the things that I thought you'd be concerned about. You all need information so you know how best to manage your condition. And you need the correct medication and support to help you minimize the complications that arises or can arise from diabetes. You want a doctor to keep an eye on you, to make sure things hasn't changed, or if it has, to be able to give you the right kind of advice. And as some of you said, you need support. You need the involvement of other health professionals to help you, because we can't do it ourselves, can we? So, if you broke it up, I'm going to ask you, because you said information, what would you like information about?
Like the person sitting over there, the lady, for example, what options are available? What does it mean to my life? Does it mean I'm going to die in 3 months? Does it mean I'm going to live another 50 years? If I manage it correctly, can I still continue smoking? Or what are the effects on my body? All these factors.
Yes, yes. You sound like you want to have general information in some specifics. What would you like from your doctor? What kind of information?
Now in the right direction.
Put you in the right direction.
For diet and everything.
Lifestyle advice. Good.
To really check that what they've told you to do, that you are doing it.
To follow up.
Just follow up,
And-
because they expect you to be doing it, but they really don't know it. Unless they've referred you.
Ooh, you're going to take my whole talk away, you know that, don't you? But hold on to that thought. It's a very important one.
I'd like to get off some of the drugs I've been put on because there are side effects. Of course, chemists don't tell you all this. Companies are the last to tell you. I found Lipitor can give you cramps in the legs. I've never had cramps in my life, but Lipitor has got me into that now, and I even take a supplement which I didn't ask the doctor, called Coenzyme Q10. I'll do anything to stop this because the doctors don't really want me to go off Lipitor, and I'm going to try and talk my doctor into asking them, can I go off it? Can I go on something that isn't that strong and gives me side effects?
Very good. That question is, I'm going to take specific questions about medications, hopefully in the second part of the talk. So the first part's just looking at general things, but you want specific information about drug and drug side effects. And you want to know if there are alternatives. And in fact, you want to know, why am I actually on this drug at all? Because it's causing me problems. And they're all very good questions, but I am going to hopefully touch on all that for you. Any other information you're looking for?
Results from my blood tests.
Apart from the results, you need the doctor to actually explain it to you in an understandable manner.
Sometimes when I'm simply asked.
Because they might just come and say your macroalbumin negative or positive and you're wondering what.
Quite often you turn around and you think, oh, it's all okay. That's not good enough.
I love it. Okay. So you want specific understanding of where you're at. Good. Now I'm going to actually now come to some of the things that I thought are important. Someone mentioned lifestyle. You know, the funny thing about lifestyle, we all know what lifestyle actually is about. It's about eating right, exercise, not smoking, not drinking too much alcohol. It's a no-brainer. You go out into the world, whether or not you have diabetes, seriously, and you ask anyone, what are healthy things to do? They'll actually say the same things. Then you look at the world and ask yourself, how many people are actually doing it? So can I put to you that knowledge or information by itself is useless? And I'm going to tell you a story about myself. This is a bit of self-disclosure, so, you know, hope you still think the same about me. About 7 years ago, I felt fantastic. The world was at my feet. I had full of beans, I thought, and I looked in the mirror and I thought, you look all right, son. So I'm walking through town, you know, I'm at Central, and I'm about to cross the road at the United Dental Hospital. I pressed the button and I'm waiting for the main to change to green. A stranger walked up. He pressed the button. He was waiting for the main to turn green. He looked at me and he said, mate, you've got man boobs. Look, I don't know how you guys react, but I literally thought, I need to get really angry, but I couldn't. I want to laugh, but I couldn't. I wanted to cry, and I didn't know how to. I wanted to say something really smart, but no words came. I just stood there. He crossed the road, and I looked down, and I went, he's right. I'm a doctor. I had a bit of high blood pressure. I had sleep apnea. And you know what? I was overweight. Do you think I was exercising and eating right? No, I wasn't. A doctor should know, didn't it? But when he told me something that flattened me, I went straight to the gym and I've been going 3-4 times a week, every week for 7 years. I love this guy. I don't know who this guy is, but I love him. So my feeling is, it was relevant. The information for me was relevant. To give you information that's irrelevant is something you would never use because you go, I know that. You all know that. Why don't you do it? Because it's not yet relevant to you. So let me suggest that there are things that actually make it difficult to put in place things that you really want to do. They're called, apart from relevance, they're called barriers, aren't there? There are things that stop us from doing the things we want to do, knowing that we should do them. So what sort of things get in the way?
Family, busy,
You're too busy? Good.
money.
Money?
Lack of motivation.
Sorry, motivation?
Lack
Lack of motivation?
Habit.
Habit?
They keep saying you should diet, yet today there's so many great foods available. It's
Yes.
so hard to keep to the diet.
The food's there. Okay? Anything else? Well, I've got a list. Yes?
I don't like the word diet. It's change your way of eating. I
Wait.
don't like the word diet.
You don't like?
I do not like the word diet.
Yes,
You
yes.
should say, I'd like to change my way of eating.
I love to. You're a very positive person. I love it. Some of the possible issues I thought of were, I'm too busy. I'm too worried and stressed out about other things in life. I actually feel okay. I'm a failure. I've tried, but I got nowhere. The doctor doesn't understand me, nor give me the time to listen. You see, the problem about life is that life is incredibly complex. And this word diet or weight loss, can I just get a show of hands in this room who hates the word go and lose some weight? Weight loss? Thank you, because I feel the same. It's a horrible word. Who doesn't know you need to lose weight? You know, it's like breathe. But why is it so hard? Why do people keep looking at you and saying, go and lose weight, and you know in their hearts they're saying, you failed again. And you really wanted to say, yes, but be in my shoes and you probably understand. And the point is that weight loss is complex and it is difficult. And there are many reasons for that. The first one is a hard one. If you are already big, the body conspires against you in many, many ways. And one of the ways it conspires against you is the hormones that's been made in the body. Just to be simple, when you start to eat, there are things in your body that tells you you're hungry and that you need to go and eat. And when you start eating, there are signals in your body that tells you you're full and to stop eating. So there are two signals. The problem is, when you start getting larger, the signals are they've gone confused, they've gone mad. So the one that tells you you're full is depleted, so you don't actually know you feel full. And the one that tells you to eat is increased, so you want to eat. It's not your fault, it's your body saying to you, eat, so you eat. And then when you eat, you don't know where to stop because nothing's really telling you to stop. Can you see how it's not easy? And then you feel sick because you eat too much. And then there's the term called comfort eating. Who's familiar with comfort eating? Why do you comfort eat? Why do we? But why? We all do it. I do it. Why do we comfort eat? Feels good because you're feeling stressed. Yeah. Now, it's amazing, isn't it? We all do it. We all start it when little kids. When little kids do something well, oh, they have a chocolate or something, and it's a reward. You know, food is a reward. Nothing wrong with that. I liked my rewards when I was a kid. But the problem is when I get to an adult, it remains a reward. I've had a bloody hard day at work. I survived it. And what do I do when I get home? I need a good feed. Not just that, I probably think a creme brulee is good too. So we comfort feed because we are under stresses. The question is, do you really know your stressors? What is it that's stressing you out? Is it all just work? Or is it issues at work? Or are there unresolved issues at home? How's your mood? How are you feeling? Is there things that's happening in your life that's been difficult? The second form of eating, I call it defensive eating. Are you familiar with defensive eating? Hands up those of you who suffered some hypos before from whatever medications you've taken. What relieves the hypos? Okay. Do you ever feel that you think you're having a hypo and to avoid the hypo you eat something?
No.
Yes. And that's not uncommon. That's actually incredibly common for people who have experienced hypos and they hate having hypos. Mild hypos, you can probably get away with it. Anybody who has experienced a major hypo, I tell you, are more frightened of a major hypo than significant complications from diabetes. So, to avoid that, what do? You eat. You eat because you don't want to feel lousy. And that's called defensive snacking. But you've got to understand, the problem is not that you're defensively snacking, it's that you're probably needing your medications reviewed because you mentioned you want the right medications. And if you're getting hypos, you really need to just sit down and say, listen, I think I'm defensively snacking. I'm scared of hypos, you need to talk to me about it. I put down boredom. I put down medications help you put on weight. Which medications help you put on weight?
Insulin.
Nexium? What else?
Insulin.
Insulin and cortisone, very good, and sulfonylureas, Gilcazar, dimicron, drugs. Yes, it does. Sorry?
What are they for? The last lot you said, what are they for? Solve for something?
Okay. Looks like I'm going to have to take it very slowly with me.
Yeah.
If you have diabetes, the first medication most doctors will put you on is a drug called Metformin. Okay? Metformin is a drug that we, to be honest with you, don't really know how it works, but we think it allows whatever insulin you've got in your body to work a little bit better. The second thing it does, and you all don't know this, but your liver is a very strange guy. He mops up sugars in the daytime, makes sugars, and when you're sleeping at night, what do you think the liver does? Releases the sugar. And you wake up in the morning, and what's happening to your sugar level? And what have you eaten through the night? So where's the sugar really coming from? Possibly the liver. Alright? So the metformin might reduce that to some degree, and we think it's good. Metformin, there are only two things about metformin. The first is that if your kidney is not very strong, you ought to either not take the maximum dose, or if it's really very weak, you shouldn't be on metformin. I mean, really weak. The second thing about metformin is if you take it for a long term, your blood cells, the red blood cells, will get a little bit bigger. For some reason, it affects your vitamin B in your bloods, and your doctor will take it either. But I challenge you one thing. Look up the internet. Just type in the words metformin and type the word cancer. What do you think it does to cancer? Gives you more cancer, or it protects you from cancer. We have no idea why. We think it's what we call an observation. It's not research, but it's observation, and it's in the medical journals. Go and read it. So we know it's cheap. We know it doesn't really harm you. We know it does some good. And in a big study called the UK PDS, the people who were on it did better with less heart problems. So you stay on metformin. I want to teach you two medical things. It's a little bit tricky, but follow me. The UK PDS was a very important study in England, thousands upon people for many years. What they had were newly diagnosed patients with diabetes, and in one arm they had the diabetes sugar levels treated tightly and just okay. And they were followed around for about maybe 7 years or so, and they looked at what happened if you treated your sugars tightly and you treated your sugars a little less tightly. The funny thing was that they found that if you treated it tightly, eye disease and kidney disease and nerve disease dropped remarkably. For every 1% reduction of your HbA1c, there was a 37% reduction in small blood vessel disease in your eye, in your kidney, in your nerves. Fantastic. But diabetes causes a problem because it causes heart attacks and strokes. That's the main thing. The risk for strokes and heart attacks is raised about threefold if you've got diabetes. And that's the big problem for us. In the UK PDS, at the end of the study, the reduction in heart attack rates did not reach what we call statistical significance. It dropped, but didn't drop enough. Then this group of people were followed 10 years later. So the study has finished. They went back to the usual lifestyle, so the control didn't wave it around a bit. 10 years later, they found that the people who were diagnosed early and treated well had less heart attacks. See, the good came later. So we begin to understand newly diagnosed patients with diabetes needs tight control early because you get gains later. What about if you've had diabetes a long time? Must be the same. If you brought your sugars down, it'll be good for you. So the study is called the CORD. You can look it up. So patients had a minimum of 10 years of diabetes. A lot of them had heart disease risks, and some had heart disease. And they tried to bring the HbA1c down to 6 fairly rapidly with whatever medications they could. Guess what happened? 22% of more patients died. Heart disease. Sorry? Hypoglycemia. Hypos, we think it's caused by hypos, setting off heart problems. So what did it teach us? That in fact, people with diabetes are not the same. Those who are early are different from those who've had it for a long time. So now, your diabetes targets, which is what you wanted to know, when the doctors read the results to you and they say, it's good, you say, yes, but what is my HbA1c? Okay? Hands up those of you who do not know what an HbA1c is. Okay. You've got red blood cells floating around in your blood, okay? And you've got sugar floating around in your blood. What happens is that in a non-diabetic, some sugar molecules get stuck to some of your red blood cells. And once they get stuck, it's like arrow dart. You can't pull them apart until the red cell dies. And the red cell lives for about 110 days, about 3 months. We know that if you're not a diabetic, about 5% of your red blood cells will be stuck with the sugar. And then when we measure it, we know how your sugar has been for the last 3 months. You understand? So if you've got a lot of sugar, a lot more red blood cells get stuck with sugar, and your HbA1c is higher, which means your control has not been so good over the last 3 months. Not to be confused with the sugar you test every day. Very different things. Now, what I was getting to with the HbA1c is simply this. You need to know your targets, but your targets are not the same. A newly diagnosed diabetic who's only using lifestyle or metformin alone to treat it, you need an HbA1c of less than 6. If you're on insulin, or if you have heart disease, it's under 7. Any other drug without insulin is under 6.5. If you get recurrent severe hypoglycemia or you've got a lot of kidney disease and heart disease, we probably go 8. So, which is your target? Do you know? Ask your GP. What should my target be? I don't know. The rules have changed. What's my target? So asking the right questions is also helpful to you. Okay? Now, I'm getting quite carried away. All right. The important thing about your barriers, because I've asked you to think about your barriers, which was stress, problems that affect you, feeling like you failed, not getting enough information, whatever it is that's your particular barrier, you need to write them down. You need to talk to your GP. Your GP needs to know what it is about you that's making it difficult for you to look after yourself. Sometimes it requires people to look at your mood, psychological conflicts. Could be financial issues, it could be anything. But it's bugging you. And when it bugs you, you don't look after yourself well. It's a funny thing. Human beings love to punish themselves when things are not going right. And we love to punish ourselves the most. Think about it. So, when it comes down to comfort eating or boredom or mood issues, talk about the doctors, but not just talk about your eating. Talk about how your mood is, what your worries are, and what your anxieties are. This is critical. If your doctor is not going to give you 10 minutes or 15 minutes to sit there and listen to you, as was the 5-minute consult that someone mentioned earlier, you probably be very good to use that doctor for when you get colds or urinary tract infections, but you might need to find someone who would sit there and talk to you and care about you as a person. If you have defensive eating problems, it is about medication, it's about hypos. Talk to your doctor, look at the medications. If you're putting on weight because of the medications such as sulfonylurea or insulin and you might be worried that it might be contributing, talk to your doctor. This is how you can get some of the best from your doctor. You're looking at minimizing complications, and we all know what are the complications of diabetes? Death from heart attacks and strokes, kidney failure, blindness.
It seems like it's all linked together somehow.
Okay, I'll tell you how. When you've got diabetes, a lot of people before they have diabetes, a lot of Australians have what's called the Metabolic Syndrome. Hands up those of you who have heard of the Metabolic Syndrome. It's a very interesting concept where the waist circumference is the most important of all the variables. If you've got a waist that's higher than for your sex and for your ethnicity, then you need 2 or 4 other criteria to say you've got a metabolic syndrome. It is a slightly high sugar level, a slightly high blood pressure, a slightly high triglyceride, and a slightly low HDL good cholesterol. 2 of these plus the waist equals metabolic syndrome, equals increased risk for heart disease, equals 5 times the risk for diabetes. Okay? So what you're saying is, somehow the risk factors seem to group together. They do, because we have the metabolic syndrome. All right? only puts you at risk of strokes and heart attacks. So we've got kidney, we've got blindness, we've got heart disease. These are the complications. And nerve disease. Let me teach you how to think about it. Diabetes attacks blood vessels. Okay? In your body, there are two types of blood vessels. The small blood vessels and the big blood vessels. Easy? The small blood vessels are the ones that are in the eye, the kidney, and the nerves. The big blood vessels, the brain, the heart. Alright? So in a funny kind of a way, as a doctor, I think about small blood vessel disease, big blood vessel disease. When you want to think about what's the best way to prevent it, we've mentioned controlling your sugar early gives you advantages in reducing heart attacks later on. But I made it very clear that reducing your sugar by 1% HbA1c reduces the small blood vessel disease by how many percent? 37. So reducing the sugar is really good to prevent blindness, kidney disease, and neuropathy. But not so good for heart attacks and strokes. So if you want to also prevent heart attack and strokes, what must you control? Blood pressure and cholesterol. Now, this is where the cholesterol question becomes really, really important. Hands up those of you who watched the Catalyst show on ABC and thought they're poisoning you. I think that journalists should be thrown out the window. I tell you why.
I stopped taking it up.
Because the journalists didn't do the following. There are two types of problems. People who have never had a heart attack wanting to avoid their first. People who have had their first heart attack wanting to avoid the second. Do you understand? Primary prevention, secondary prevention. Every single study in the world in secondary prevention showed that the reduction for heart attacks using statins is unbelievable. If you got a first heart attack and you don't want to take statins, fair enough, you might as well go walk down the middle of King Street, George Street and not look for the traffic lights, just cross it. Because it's just that. It works. But if you've got primary prevention and you want to take the drug not to have a heart attack, is the evidence there? The answer is no, not really, unless you have, you ready for this? Diabetes. You want to write this down if you want to. It's called CARDS, C-A-R-D-S, CARDS study. And next to it, put the horrible word which someone here is very unhappy about. It's Lipitor, it's atorvastatin, A-T-O-R-V-A-S-T-A-T-I-N. So it's CARDS study atorvastatin. And this is a group of diabetic patients who never have heart disease. They're well, their heart's fine, their cholesterol level is from 3.5 upwards. Excuse me, 3.5 is a fabulous cholesterol level, isn't it? And they were put on 10 milligrams of Lipitor, which is nothing. Because they didn't need it. So we give them a little bit and see what happens. I'll tell you what happened. 37% reduction in strokes and a 27% reduction, I think, in heart attacks. All right? You like those numbers? I like those numbers. So it does work. Your question, however, is it causes me aches and pains. So let me just recap. No evidence, unless you're in very high risk, your doctor has to calculate, oh golly, your doctor has to calculate your absolute cardiovascular risk. If you ever walked up to your GP and said, Doc, what is my absolute cardiovascular risk? He or she might look at you and go, I don't know. Because, you know, I've been teaching the young doctors to calculate this, and I guarantee you 9 out of 10 still don't. But the absolute cardiovascular risk is actually incredibly important. If you've got a risk that's low, you don't need drugs. If you've got a risk that's moderate, you will need drugs, but not as aggressively. But if it's high, then take it because you need it. You need to know your absolute cardiovascular risk. Diabetes increases your absolute cardiovascular risk. So having said that, primary prevention is not helpful in patients who don't have high absolute cardiovascular risks, who don't have heart disease, and who don't have diabetes. once you progress to the other side, there is evidence it is helpful. If you've had one heart attack, there's a lot of evidence that says it's very helpful. Does that help? If one statin causes you aches and pains, try another. Let me tell you one. Who has heard of a drug called Ezetrol? Or Easytrol? Okay? It's also found in Victorin and Atrazate. Now, what this drug does, it reduces the absorption of cholesterol from your gut, as opposed to the statins, which reduces the production of cholesterol from your liver. And together, they work very well. But the problem is that there was a study done that looked at a statin alone and a statin with Ezetrol. Guess what? No brainer. The Ezetrol reduced the cholesterol more than this one. But when they looked at the thickening of the blood vessels, there was no change. It thickened just as well as the thickening. So the fact your cholesterol got lower didn't stop the blockage of the artery. Okay? So if you want to take Ezetrol alone, I'd say don't. There's another drug called fenofibrate, which is another drug that lowers cholesterol. And there's a big study called the FIELD study, and Australia took part in the FIELD study. The problem with that is that it didn't show any reductions in heart attack rates, even though it reduced your cholesterol. So my horrible suggestion to you with the aches and pains from Ezetrol is, and you're right about the coenzyme Q10, it does deplete. Yeah, the CoQ, all of you need to know that when you take a statin, your body's amount of coenzyme Q10, which is necessary for energy production in the mitochondria, is reduced. And you can supplement with coenzyme Q10, which may reverse some problems. Not always. But try a different statin is a possibility. Or a lower dose statin. And I have a heart specialist who says some patients are so sensitive, they only need to take the statin 2 or 3 times a week. So it's better than nothing. So there are ways around it.
So do we buy the coenzyme Q10?
Yeah, you can get it from any health food store. So I'm not saying do it, I'm just saying it happens, and I'm glad you brought it up. The other thing is blood pressure. 140/90 is what the Europeans and Americans have got the targets up to. Australia is still 130/85. Okay? And I'm not going to tell you to go for a higher target until we do it. But the reason for that, again, is that the lower numbers has not translated to greater increase or increased reduction of heart attacks. So because people with low blood pressure, issues with the side effects, but no improvements in the outcome. I want to talk to you about side effects. If I told you that if you took this chemical and you had too much of it, your brain would swell, you'd go into a coma, and you'd die within hours of ingestion. Would you ever take it? Yeah, it's water. Okay? And this is what happened in one of the stupid talk shows where they had challenges. Who can drink the most water in the shortest amount of time? And this woman died because of that very reason, from drinking too much water. So what am I trying to tell you? Everything has a side effect, even water. If you want to stop a drug because you think you've got a side effect, you need to really document it and talk to the doctor about it. If you want to stop a drug because you fear having a side effect, you need to understand why you're taking the drug, and you've got to weigh the difference between the possibility of getting a side effect versus what would happen to my big blood vessel disease or what would happen to my small blood vessel disease. It's never going to be easy. But for you to make a decision, it's that information you see. Doc, talk to me about the risks, benefits of this medication. Let me also tell you that this is a crazy time to have diabetes type 2 in Australia or in the world. Do you know how many new classes of drugs have hit the market?
This year?
In the last 3 years? Yeah, 3 or 4 years. Seriously, it's crazy. And a lot of doctors still don't know how to use them. Okay, so let me spend a few moments just talking to you about where diabetes is slowly headed. For a very long time, metformin, insulin, and sulfonylurea, such as Diabex, glucoside, diamicron, they're the only things we had. That's all we had. Novamix, Mixtard. And then we had a new group of drugs called the thiazolidinediones, Actos, and Avandia. They looked like the ants' pants. It was a drug that tackled diabetes at the core of diabetes. It's a thing called insulin resistance. We were, the Holy Grail is here, let's all bow to the Holy Grail. Until there was a study that said, oh, we think that rosy glitazone causes more heart attacks. And then we put it away, maybe not. And it can cause heart failure, put on weight, but it does bring the weight, sugar goes down. So we pulled away from that. And that made the rest of the world ask the question, man, we're treating you all with sugar issues because we want to prevent the heart attacks. Why in the world are we giving you drugs that cause heart attacks? If we are ever going to put a drug out on the market in the future, it's going to have to be safe. I want to know when I put a drug out there, I'm not going to give you more heart attacks. Okay? So now all the new drugs have to undergo what's called cardiovascular safety trials to prove they don't cause heart attacks. So the new classes at least have gone past the first hurdle. The first class of drugs have been out here for a while now. I mean, the second class of drugs, they're called incretins. Anybody here know the incretins?
Is that Junivant?
No, it's, yes, Junivant, very good. Januvia, sitagliptin is one, it's the gliptins. Okay. The incretin is a very interesting thing. Your body makes it. Your body releases incretins when you eat. And the incretins are very clever things. It tells you you're full. And it reduces the sugar. Okay? Fabulous drug. And then they found, I don't know how they found this, but the saliva of the Gila monster in the Arizona desert has a chemical that is very, very, very similar to human incretin. Okay? And we went, gee, I wonder what happens if we gave ourselves these sort of shots. Could we look like a Gila monster now? The point is, it actually works really well. Now, there are two things you've got to understand. When the body releases what we call GLP-1, it stays in your bloodstream, bringing the sugar level down for how long? Minutes. And then your body breaks it down. So they asked the question, what if we made it last longer? What if we blocked the chemical that breaks it down and make your incretin last longer? Would it work? And that's exactly how Genumac works. It blocks the enzyme that breaks down the GLP-1. And it does work. It does bring the sugar level down. But it doesn't really make you feel full. It doesn't really make you lose weight, but it doesn't cause hypos. Crazy drugs, let me tell you. When you've got diabetes, your pancreas has two problems with it. Most of us think of one. It doesn't make enough sugar, correct? There's another one, where it actually makes too much glucagon. Now, hands up those of you who use insulin. Do you all have a glucagon pen at home? Okay. What's a glucagon pen for? Hypos when you can't respond. Okay, you should have it at home. Please get from your doctor a glucagon pen. You don't need it, but whoever's looking after you will be freaking out and wondering what to do. They can administer the glucagon pen. The glucagon goes to your liver and releases sugar from the liver, hence reversing the hypos. But when you've got diabetes, the amount of glucagon that's been released is high or low, you think? It's high. It should be low. You've already got enough sugar in the blood. Then this stupid little thing goes to your liver and says, excuse me, can you release more sugar? And the sugar goes even higher. So the incretins do this. It blocks the production of glucagon, reduces the amount of sugars put up in the liver, and it stimulates these insulin-producing cells and say, come on, you need more insulin. But it's very clever. This is where it completely is different to sulfonylureas and the diamicron. The diamicron is completely, it's like, I don't care whether you've eaten or not, I'm just going to keep stimulating you as long as I'm here. I'm going to irritate you like a mozzie around your head. I just keep flying around all the time. The incretin says, I will work only when your sugar level's high, and when it's normal, I will stop working. So which one causes hypos? The one that works all the time, the sulfonylurea, the diamicron. And which one is going to cause less hypo? The incretins, right? Now, the incretins, as I said, the DPP4 is not as strong because it blocks the enzyme. But giving yourself injections of exenatide, which is an incretin, is far more powerful. Brings the sugar level down faster, more powerfully. The weight loss is quite significant with exenatide, but we're always told never sell the drug for its weight loss, but it does. But it causes nausea. And in fact, my patients, believe it or not, love the nausea to a degree because they eat less. So you've got these incretin drugs that can bring your sugar level down without causing hypos, without putting on weight, in fact, helping you to lose weight. How unusual is that? Every drug we had before causes a hypo and we can put on weight. There's a third group of drug that's just come out. It's a really crazy drug. It's called the sodium glucose luminal transporter 2, long name, SGLT2. But I want you to think of it like this. 150 years ago, don't ask me why, but French people do funny things. They boiled the bark of the apple tree. And there was a drug in the apple tree bark called fluorescin that made you pee out sugar. And so the whole group of drugs does this. When your kidney is working normally, you filter out of your blood 180 grams of sugar a day, every day. All right? How much of the sugar is taken back into your body every day? Should be 180. That's why you've got no sugars in your urine, usually. Okay? Your body filters at 180, you absorb 180. What if we block the absorption of the sugar so that the sugar doesn't get taken back, but you lose the sugar here? What's going to happen to sugar in your blood? It'll go down. It'll go down whether or not you're insulin, it'll go down. And when you lose sugar, what could happen to your weight? It goes down. And because it doesn't release insulin, getting rid of the sugar, do you get hypos? No. You see, that's another group of drugs that can potentially bring the sugar level down, but not cause hypos. But if you pee sugars out in your urine, you can get thrush, you can get urinary infections, and it can give you one extra pee a day. So, let me assure you that if you get hypos, minor ones, you learn to deal with it. If you've got major ones, or, this is what I want to say, I look around and some of you are young enough to do this. Work with dangerous machinery, drive a train, a taxi, have shift work and cannot have the snacks when you should have a snack, you're more prone to hypos. Okay, I'm not saying you need these new drugs, but there are new drugs out there if hypo is a worry for you. Okay, I'm not selling these drugs, I'm just telling you it exists. So, what some of your conversations with your doctor might be, I need to talk to you about hypos. What are the alternatives? Because someone wanted to know alternatives. And we have alternatives. Now, I'll tell you what I'm going to do. I'm just going to pretty much bring it to my side to a halt as I take questions, because I've said what I need to say now, and I need to work with you because you need to ask me questions, and I'll see if I've got an answer for you. So I'll end my formal part now, and I'll take questions from the floor.
Dynamite.
Yes?
It's only available in 500 mg, and I would be able to tailor it a little bit. I've tried cutting one in half, it's a little bit too much.
Okay.
You know, 500, it's not enough.
Okay. It's not diamicron, it's Diabax, or it's Metformin that comes as 500. Diamicron comes as 60 or 80. And they're different drugs. Diamicron is a sulfonylurea, and Diabax is Metformin. Let me tell you that if your kidneys are good, there is no reason in the world why you would take 250. It doesn't work. The actual dose you need is between 1,500 milligrams to 2,000 milligrams. Who thinks that's a strong dose, by the way? 2,000. 2,000, is that a strong dose?
Yes.
Who takes Coversil 5? Is that strong or weak? Weaker. Let me give you a story. I'll choose my friend here. We got two villages separated by a hill. All right? We got one gigantic table to move. These fellas from his village are huge and they're strong, and they need 10 of them to move this gigantic table. My village are full of tiny little people. To move the same people takes 50 of us to move the table. 10 of them. Who's stronger? Him. He needed 10, you needed 50. If you needed 5 Coversil to bring your blood pressure down, that drug is wonderfully powerful. Because you need 1,000 of the metformin to do a job. It's not powerful. It's the wrong way around, guys. You're thinking wrongly. The big numbers doesn't mean it's powerful, it means it's weak. Okay? So that's number one. Number two is your metformin. You need to use what we call a therapeutic dose, 1.5 to 2, otherwise it's not going to work. But if you get the side effects of the funny tummy, the diarrhea, you change from the immediate release to the extended release, and that might make it a bit better. Okay?
I've just started taking the Junimet, and I've read somewhere that it causes pancreatic cancer, and that one's so wrong.
Thank you. I love that. Okay. If you now scour the literature for pancreatic cancer and pancreatitis, you will find that subsequent studies have actually shown it not to be the case. So let me assure you that I've been to a talk, Professor Ted Wu, I'm going to do one this weekend, and shot down in flames. Don't worry about the pancreatic cancer. Don't worry about the pancreatitis. Having diabetes puts you at higher risk of pancreatitis anyway. It doesn't seem to increase it significantly. Okay? The only thing that you need to look at is that I think Genumet is now coming up with an extended release platform as well. Onglyza is saxagliptin. It's also a gliptin. Hers is a sitagliptin. Onglyza is saxagliptin. It's also an incretin, and it comes with an extended release metformin, and it's called Compiglyza. So it's an incretin. Sorry.
Just what was the study? Because I've read up a lot about the pancreatic cancer.
Okay, you know what this man did? He actually did autopsy studies of patients, and it's only a small number of patients, and he found there was hyperplasia of the increase in growth size of pancreas in some patients, and he made the wonderful leap of faith that if you got this, it's going to be cancer, and he wrote it, and everybody goes, "Oh, you can't do that." But he had already written the article. But subsequently, nothing showed that it is a signal.
Just wondering, did you say that 1,000 of metformin isn't a therapeutic dose?
No. Let me explain to you. I like to think of it this way. Actually, I love this story. It's slightly long. Many years ago, China wrote a study called the Dachi study, where people who were found to be pre-diabetic were given diet and exercise and lost weight, and they found that less people had diabetes than those who didn't. So they wrote it up. The Americans, being Americans, didn't believe the Chinese and spent about $174 million on what they call the diabetes prevention program, 3 arms. The first arm is good information. Can you believe it? The first arm, they were the control. They're the ones who did the worst. Because the second arm was not just good advice, they were followed up every week by a dietitian, an exercise physiologist that ring you and make you turn up. You got to do the exercise. Your food was checked, your weight was checked. They spent a lot of money on this second arm. The third arm was with Metformin, 850 milligrams twice a day. So that's 1,700 milligrams twice a day. So what they found was the people given good advice, a certain number had diabetes. This one, 100 a day, had 58% less having diabetes. But they had to be hounded. The group taking Metformin, 850 milligrams twice a day, had 39% less patients becoming diabetic.
About 1,000 release once a day.
Yes, well, I know, but what I'm trying to tell you is that even in a pre-diabetic, we use 1,700. So a lot of us who deal with diabetes would love to get to 2,000 if we can, if it doesn't cause you gut problems, okay? And provided the kidney functions good.
Just on that one, what's the difference between just straight Metformin and the XR?
Yeah, the XR, let me tell you, sometimes the XR is just a shell with the drug embedded in it, and sometimes it goes through your body and comes out and you go, oh, it's come up looking just like it is. No, the drug's gone. So it's a very slow release form that's released over 24 hours, whereas the immediate release is released like this twice a day. And then the level in your blood goes up. You feel the side effects, nausea, bit of diarrhea. So the extended release may reduce some of the upset stomachs. Same drug.
Also for better control of fasting, sugar, I think.
Because it's given at night, it is probably better for fasting.
How about Genomate? What is the effective doses?
Sorry?
Genomate. What is the effective doses before you're talking about Metformin?
Yeah. Look, there's only one dose of Januvia, okay? And when you go into the extended release, they half the dose with 1,000, so you've got to take 2 tablets at night. It's 100 and 2,000. So you work up to the 2,000 milligrams of Metformin. But the Januvia dose is the same.
I was told that for me to transfer to another doctor, I've got to pay a large amount to my GP for my records to be transferred. Is that correct?
It's just a rumor that they want everyone to go on e-records. Isn't that true, doctor?
If a patient comes to another doctor's practice, say I come to see you, and I like you a lot, I sign an authority to release medical notes that you will send to you. Sometimes it's $20 at the most. Listen, guys, is the doctor using computers? Do you know how hard it is to get your records out on the computer? It takes like 10 seconds. They put it on the disk.
That's what my issue is with using the computer. I go into my doctor, she makes no eye contact with me, and just immediately goes to the computer. I can be in there for the 5 minutes she gives me, but there's no eye contact. She wouldn't have a clue if I was red or yellow, black or green. And she just dispenses, and she always says, what are you here for? And I just think, there's no, you know what I mean?
I know exactly what you mean. I'm not in a position to give you any advice because, but maybe your friends might tell you what to do.
How would I go? Because I've got records. They said, well, most of the GPs around here will charge for your records.
$20 is the max, I think.
Doctors are making profit out of it. Yes.
We give ours for free.
You know those new medicines we have, but they're not insulin. I can't remember the name. Byetta. What do you think of those?
That's exenatide. That's the one I was talking to you about, which is a GLP-1. You know that's sitting now in Canberra, and it costs too much, so Australia is not in a position to subsidise it. But I pray for the day they do. Byetta is given twice a day. Bydureon is Byetta, given once a week. Better blood sugar control, better weight loss. Bydureon. Fabulous. but it's too expensive for the government at the moment. But who knows one day?
Not on the PBS, in other words.
It's not a living. It's you can buy it on a private script. It's about $200 a month.
Unless you have an HPI.
Sorry.
Unless you have an HPI, one of those drugs that I was told, and I think it's one of these incretins you're talking about, I was told it was $200, but because I had a 7.1 reading at one time in my life,
Yes.
they were able to give it to me.
Yeah, that's Viata. That's the twice-a-day injections. I'm talking about the once-a-week injection. That's not yet available. Ask what your kidney function is, and if it, I would take it. If your kidney function is good, I'd take it.
You have the heart attack.
Yes.
But it says on the Metformin form, don't give it to anybody with heart problems.
I give it to my patients with heart problems. What you worry about is infections and heart failure that may put you at risk of an acid condition in your blood. Okay? But that's even more likely if your kidney is weak. So I always look at the kidney. Holding it back, the point about the metformin was that the patients in the UK PDS who took metformin probably had less heart attacks. But it's not what I would hold back from in the treatment of diabetes if you have a heart attack. I would not use Actos, and I would not use Avandia.
Just one insisting on that comment and the other bit
Well, this is a rude question, but just looking at you, you've done really, really well. Okay? If your HbA1c is okay, I'd just travel with it. And it's not like you must have it. It's just that when you do, you might need less of the other drugs. Okay? So if you were young, I'd say you definitely need it. She needs it. She definitely needs it.
Just a general question. You have, say, HbA1c is 7, and the doctor says, oh, I've got to put your tablets up, I've got to give you insulin now. And I say, no. How wrong am I?
If this is the first time you've got past 7, I wouldn't do it. You've got to have 2 readings above 7 for me to say, yep, you've lost control. Alright? And it's up to you to think about why you might have reached 7 and whether there might be things in your life you could change to get yourself there. There's one thing I didn't talk about. I think I should, only for the sake of actually mentioning it for completeness sake. It's a fairly invasive thing that people talk about, is bariatric surgery. What do you all feel about it? Just hands up.
Worried about infection afterwards, being a diabetic, and I'm frightened of
Infections. Yep.
Good results.
Are there any good results? You said they do give good results?
I've heard it.
Yep.
Worse for Jamie Thacker.
I heard there's complications.
You heard this
Like
complications.
a lot of people, like they can't guarantee that you're going to be well. Like my cousin, she's had like 2, because she's got 2 kids and she's single mama. She said, what if something happens to me? My kids are going to be, orphans,
Yep.
So,
Okay. Let me just tell you, there are 4 things happening. The first, of course, is everybody knows it's a lap band. It's actually not hard to put in. It's a very simple procedure with just telescoping and put a little band around. It's completely reversible. It works because you feel that the food doesn't go down. You can't eat a lot because it feels awful. You vomit it up. But you can drink whatever you want to. So you really want to lose weight, because I have a patient who actually put on weight after the lap band. And she was comfort feeding because she was a very stressful job, but she managed to blend her Mars bars into her sleeve. So that is not really a good way to do it. Sleeve gastrectomy, where they cut out some of your stomach, gives you a better result. That can also be done with a telescope, so it has less infection, less complications. The one that works best is a Roux and Pass. It's a big operation where they bypass various things, gives you the biggest reduction in sugar levels and weight loss. There's one that's just out now, and I just don't want to sell it, but I saw it when I was in Barcelona last year. It's called Endobarrier, and it's quite interesting. it's just a normal endoscope. So, you know, when you have to look for ulcers, and they put this little plastic sleeve into your duodenum, it sits there for a year. 70% of patients either go off the medication or half the medications they're on, and they lose 20% of the body excess body, 20% of the body weight in a year. And it does nothing other than, wait for this, change the hormone levels in your body. The one I was talking about, the ones that you forget about, you know, the ones that make you want to eat and can't stop, it reverses and the patient feels full. So I actually have 2 patients who've had it done. It costs a lot of money. It's $11,000, so it's not for everybody. But the weight loss has been 12 kilograms for one patient in 4 months. And he is walking in saying, look at me. You know, so it worked, but it costs a heck of a lot of money. It's new. I think we should watch it a little bit more before anybody thinks about it.
Thanks, Doctor. Good question. What's the ideal blood pressure with diabetes?
Sorry?
Ideal blood pressure with diabetes.
Very important. If you control your blood pressure together with your sugar level, you will reduce your risk for strokes and heart attacks significantly. Very important. What's the reading? I mentioned in Australia 130/85, but in Europe they're moving to 140/90. We stay 130/85. 130/85. And it's not true that if you've got protein in your urine you need lower. You don't. 130/85. Okay. Thank you very much, ladies and gentlemen.